with you, and we're going to talk about pharmacology. Let's see if I can move this. Nope, I can't. All right. Let me see, I'm trying to find a picture of you. There you are. Okay, so we're looking at selected pharmacology content review and test taking strategies. Dr. Haylett was not able to be with us today. However, I'll just reassure you, I have taught pharmacology before, and I'm pretty familiar with what the NCLEX is expecting and ATI and all of that on pharmacology. So that's what we're going to be doing, looking at some of this material and some tips to kind of help you think about, okay, what happens if I don't really know what a drug is? All right, so let's get started. Stop me at any time. As we get towards the end and some interactions, I'm going to ask questions of you as students because I want you to be involved in the practicing that we're going to do. So basically, this is what the National Council of State Boards of Nursing tells us, is that you're going to have to provide care related to the administration of medications and parenteral therapies in which you are familiar with. So you know that this is something that you're going to do a lot of, okay? All right. On your NCLEX detailed test plan, this is what you're going to be seeing for pharmacology. We kind of briefly reviewed it when we did our introduction into the NCLEX at the beginning of the quarter. But you can see that there's quite a few information. It's quite a few percentages related to pharmacology and parenteral therapies. And as I had mentioned before, be sure that you are focusing in on this. Okay. Did y'all hear me? I heard myself all of a sudden. Okay, we're good. Okay, adverse effects, of course, we're looking at expected actions, because really what we want to do is when we look at a medication, we want to see, okay, I'm going to give this medication, but what's the end game? What is the outcome that we want to see for our patient? That's the key of understanding pharmacology, truly, is to, I'm going to give this med, I know the side effects, I know this, but what do we really want to see as an expected outcome? And so that's important to always remember those, the outcomes of what should happen to our patient, okay? For instance, if you give a beta blocker, then where your expected outcome is that you're going to have a slower heart rate, right? A slower pulse. So you know what you want to be doing with that patient. The other thing is blood and blood products, the use of the different types of bloods and all of those things, and how to handle transfusion reactions, which you actually will review not only in my comprehensive predictor, but you will also most likely go through that with Dr. Simmons. I'm not sure if that's what's on her done, but she's done that before. So hopefully you'll get plenty of information, because the NCLEX does want to know, what are you going to do if a patient is allergic to blood? What's going to happen? Okay, central venous devices is also part of that, of course. Dosage calc you're familiar with. The overview of just basic medication administration. The different type, how do you give medications, and of course the parental pieces, pain management, and TPN. So those are all things that the NCLEX will be testing you on, or can test you on, I should say. You may not get questions on all of this. All right, so 12 to 18% of your questions will be pharm information. So for the pharmacology strategies, these are the things that you probably know already, and you can apply these for all of your questions, but I put them up here just as a reminder that you can do this even with pharmacology questions. You're going to read the question, you're going to look at those strategic words, you're going to, what is the subject? Always ask yourself, what is the subject of this little scenario that I've been given? Who is my client? Is it a person? Is it a community? What is the who is the person involved there? And of course, you can use elimination processing, but remember, in most NCLEX questions, ATI questions, and quite a few of my questions, all the questions could be right. I mean, all the responses could be correct. So you have to think about, what is the safest thing that I could do for my patient? What is the minimal invasiveness thing that I can do for my patient? Which would be the best thing to do? Even if a question doesn't say best, they're asking you, what is the best response? Okay, just a reminder of that. Of course, you have lots of nursing knowledge, and we're going to go over some of these principles and general guidelines in a minute as well. And as you are preparing for your comprehensive and your NCLEX, be sure you are reading through any rationales that the author gives when you look at those questions and the responses. And they also, a lot of times, will give test taking strategies. I know the Saunders book does that, and so does the Success book. All right, so just a quick review of that. Now, some general guidelines. Again, class, this should be nothing new to you, but just a reminder to kind of bring it all together for you. Some general guidelines about medications. As you can see, we know that medication has to be absorbed. We need to know that it has to go through some type of distribution process. How does it get into the body? What happens to it? Who metabolizes it? Usually it's the liver, but not always. Most of the time it is. And where is it going to be excreted? You know, meds can be excreted through the skin, the lungs, through the stool, many places. And all of those, remember, have something to do with the age of the patient. So when we're talking in gero, obviously we know that if our patients have decreased liver function or decreased kidney function, then there's going to be a little more attention on that medication and how it is being excreted or metabolized or distributed. We do know that the older patient, of course, and children are most likely to become toxic if we don't monitor them carefully. Again, some medications are not given in pregnancy or even during breastfeeding. For instance, isotretinoin is a teratogenic to the fetus, and so we are not going to give that particular medicine. So, but you learn those as you go through. And in fact, most of the medications that we have now are not really given to pregnant women. Okay. All right. Don't forget your antacids. An important piece with antacids is because we don't usually administer those with another medication because there's going to be a problem with the absorption of other meds. Can someone tell the class when, if you're going to give an antacid in the beginning before you give your meds, how soon before you give meds should you give that antacid?
Is it 2 hours?
At least 1 hour. At least 1 hour. That's usually the general time frame, because you want to make sure that it gets into the body and gets through. Goes through its processing. And after you have given other meds and you go, oh no, I forgot the antacid. You may have to wait several hours because of that, because you have all these other medications that are going through the process. And so the antacids can actually impact the absorption of all these other medications. So that's an important key. Generic, enteric coated, sustained released. I'm sure you remember that we don't crush those. We should never be opening capsules, although there are some meds out there that we have known to open. When I was working in one of the PCU units, lots of our older geriatric patients were getting potassium supplements, and potassium comes in these huge pills. It's usually in a capsule, or at least the product that we were using, and we had no choice but to open up that capsule, all right, and put it in some pudding or some applesauce for that patient. But just remember, in general, we should not be opening any capsules, okay? Always include, for nursing interventions, always think about the intended effects. I've already mentioned this also. And know the toxic effects of your medication. You don't have to know toxic effects for every medication, individual medication, but know the classification of the medication and what is the general things that could happen to a patient. All right, for instance, the mycins, that particular classification of anti-infective, is ototoxic in most cases. So we want to be very careful with the use of those mycins. So, you're not memorizing every detail of a drug. That's why we have drug books. But the NCLEX wants you to be able to at least identify what are you going to do when you have a patient on a particular med, right? Don't forget your patient education. We also know never to adjust or change a medication dosage or or any of those things without healthcare providers' orders for that. When do you withhold a medication? Somebody give me an example of when you might withhold a medication.
Something like metoprolol or something if the heart rate's too low.
Okay, if the heart rate is really, really low, that would be a possibility. Then we might have to hold it. Yes. What would you document on the EMR?
The vital signs and the directions from, because usually the medication will have the directions when to hold it.
Exactly. Yeah.
And why. Yeah.
Yes, usually they do, but nursing judgment comes into play here. There are some things that they don't give us those parameters. It's always nice to have parameters, but the doctors don't always give parameters, and neither does the pharmacy. So you use your nursing judgment as to whether you should be giving this particular medication or not. For instance, if you have a patient that's nauseated and might vomit, we're going to hold some medications, right? Because we're not going to give them if we think they're going to upchuck all those medications. And there's no way that pharmacy is going to write that on that EMR. So just keep in mind that even if it doesn't say specific parameters, then use the nursing judgment that you have based on the patient's condition, based on what's going on with them, the medication, those types of things. And if it's a medication that the patient really, really needs, and there might be either an IV form or a rectal form, you can always contact the healthcare provider and tell them the patient's throwing up. Is there a way that we could give this medication in a different form? We can't change the form without an order, but the healthcare provider may go, oh yeah, let's go ahead and order that in an IV form. Okay. So there are times when you can do that. We also know that we tell our patients not to take over-the-counter medications unless the healthcare provider approves. But I can tell you, in the real world, y'all know that patients take all kinds of stuff over the counter. But it's a good thing to know what medications they are. That's why we do that medication reconciliation when they come into the hospital and before they're discharged. So we want to make sure that there's no interaction with the medications. Right. We have to make sure we're teaching our clients how to administer the medications. And of course, a lot of this you did learn in fundamentals, but you've been using it since you've been out there practicing as well already. We need to teach our clients a lot of things about the side effects. And you know that you're not going to use all the side effects that are in some drug book, all right, or some drug monograph, because it would just drive the patient crazy or confuse them. So this is the most common ones. And in nursing school, you have been learning the most basic of side effects, right? All right, so for instance, we know that taking iron on an empty stomach can cause what? Nausea, right? So we want to make sure that they don't take that iron without eating something. And there's other meds, of course, that's just an example. But we want to be sure that we are explaining all of that to our patients. We also teach our patients about how to take their medications. One of the things that we found is that in particularly this country and other countries as well, is there's something called health literacy. And sometimes patients don't understand. If we tell a patient to take a medication twice a day, we have to be clear on when that twice a day means, because some patients may think, okay, well, I'll take it twice a day. It's due at 9 o'clock in the morning. Okay, at 10:30, I'm going to take it again. That's twice a day. So we have to be careful and very clear in our instructions to our patients when we discharge them, particularly if we're working in the hospital. Okay. We always tell them not to alcohol or smoking. Alcohol is should never be taken with medications. We do know that. All right, so that's just that generalization there. We do suggest some medic alert bracelets for medications for patients on a blood thinner, or actually it's not a blood thinner, it's an anticoagulant. I should use the proper term here. Medic alert bracelets. sometimes if they're diabetic, those types of things. And we need to make sure our clients are well informed that they need to follow up with their healthcare provider. Remember these. I hope you are still doing your 6 rights of medication administration. You should be doing that regardless of if you are a student or if you are a registered nurse. You should always make sure you have that right client, the right drug, you're going to get the right dose, the route, of course, time, and you're going to document it. And so how many checks must we do even as an RN? How many checks are you going to do on that drug? Did I see a 3? There you go. Absolutely. When you take it out of the medication dispenser, when and after you've done that, then you're going to check it again once you have all your meds, and then you're going to check it again right before you give it to the patient. Important to remember. And I know in nursing it is a very busy world. We're always giving meds, but these things cannot be worked around. It must be done or patients will suffer. Okay, just remember that. A couple more tips. You are probably very familiar also that some medications can be given for different reasons, like the black box that's on some of those medications. So a patient may be taking a med and you think it's for blood pressure, but maybe it's not. Maybe it's for taking care of AFib. For instance, metoprolol can be given to reduce the blood pressure, but it also helps to calm the atrial nerves, the nerves in the atrium, so the heart will not try to go into AFib as much. Right? So you have to know, why are we really giving it? Maybe the patient doesn't have a high blood pressure, so why they're getting it. So important to know that. Okay, why are they getting it? Know also that there's a difference between side effects and there's a difference between adverse effects, and I put the definitions there for you. All right. Usually adverse effects are the ones that are potentially life-threatening. All right. Life-threatening, of course. All right. Now, if you want to determine the effectiveness, and again, a lot of these concepts are written within your questions on your NCLEX and your ATI questions. So if you want to see the effectiveness, you're going to assess for symptoms, or you're going to assess for a lack of symptoms, right? For the reason the medication was prescribed. We also, like for instance, go back to metoprolol. If you're looking at metoprolol and it was given to lower blood pressure, well, you're going to look at the vital signs and you're going to check that blood pressure every time or right before you give this particular med. In fact, that should be a standard practice, that you're taking those pulses and blood pressures immediately before you give the med. Don't forget that sometimes we have techs and nursing assistants to help us with vital signs. Say they take them at 5 or 6 in the morning and your meds maybe due at 8 o'clock. You cannot use that vital sign in order to give medications. You must take that blood pressure, that pulse. And even if it doesn't say pulse, try to remember heart rate and blood pressure tend to go together. So you would always want to include your pulse when you're documenting. What's the heart rate? What's the pulse? All right. Okay, the other thing I showed you here is talking about grapefruit juice. We talked yesterday in Gero. I am going to bring in some Gero things because I think it was very fascinating to have a grapefruit on the pictures. But I did promise you that there is a reason why we don't want to use grapefruit juice or even have it anywhere in the hospital. So it actually inhibits this particular enzyme, which is found in the liver and intestinal wall. And I have a detailed description on the next slide. I'm not going to read it to you, but you'll find it fascinating. Okay. Always remember, no alcohol. Don't limit the intake. So here's this huge, long discussion. I think it's very fascinating to read this. Have you ever really read why we don't give grapefruit juice, or have you just learned that you don't give it? I'm curious.
I never looked into it, but then also someone said that now they have grapefruit juice that is okay. It's like a certain, it's okay to take with medication, but I haven't looked into that as well. I'm not sure if
Right.
that's true.
I have not heard that, but I know they're always coming up with stuff. Okay, if they can make a grapefruit juice without this problem, that's great. But that's interesting. I'm gonna have to look that up since I do like pharmacology. I want you to read this, and so let's see, Andrew, would you read this? Because if you've never read why this grapefruit juice is delicious but not with meds, how about this, Andrew? Go ahead.
Yes, ma'am. Grapefruit juice causes absorption problems with many medications. It inhibits cytochrome P450 found in the liver and the intestinal wall. Cytochrome P450 enzymes are essential for the production of cholesterol, steroids, prostacyclins, and thromboxane, A2. They are also necessary for the detoxification of foreign chemicals and the metabolism of drugs. The enzyme only interacts with the juice in the intestines, so the metabolism of oral medications are altered. Grapefruit juice inhibits the action of this enzyme, resulting in clinical significant drug-to-drug interactions that can cause unanticipated adverse reactions or therapeutic failures. Interactions with warfarin, antidepressants, anti-epileptic drugs, and statins often involve the cytochrome P450 enzymes. Basically, the action of the grapefruit juice reduces the metabolic activation of many medications. For instance, if the blood thinner warfarin cannot be metabolized, the blood level increases, which can interact with other medications and or cause significant bleeding. One glass of the juice can alter drug metabolism for 3 days. So you can see why hospitals stop serving the juice.
Yeah, thank you, Andrew. Now, if you're ever curious, now you know why we've always teach no grapefruit juice. But that would be very interesting if they do have a grapefruit juice that you can use, or maybe they're switching some medications. But in general, no grapefruit juice. Okay. And patients don't know that. So you might want to remind the patients of that. Okay. Or think about it, if you have a patient that's coming in and they're having some bleeding issues because they're on this anticoagulant, and you do your little nutritional assessment and they drink 3 glasses of grapefruit juice a day, think it could be the grapefruit juice is causing the problem, right? You have to look at bigger other things, but you have to also look at a simple thing like grapefruit juice. All right. Okay. Make sure about the herbal medications that you're familiar with what they're taking, okay, this because of the interactions of some, and you've probably learned some of those, right? If a patient complains or they have a lab value or other assessment finding that indicates that there's an adverse effect secondary to a medication, we must intervene. We have to do something. Usually it's some action that the nurse can take. Many times, particularly if it's an adverse reaction, after we have taken care of the patient, then we will call the healthcare provider. But always remember, NCLEX is looking at what can the nurse do before they call the doctor, right? They want to know if you can be a safe nurse. So we always have to, in most cases, I won't use say always, but in 99% of the cases, we have to do something first, okay? Just a tip there. Of course, you want to keep up with all the standard of practices for the different conditions and diseases. And like today, it was just shared with us that there's particularly maybe a grapefruit juice they're investigating to see if they can drink the grapefruit juice. So you have to just kind of keep up with what's going on in your practice. All right. The other thing is about a diagnostic test. Just always remember that sometimes diagnostic tests have nothing to do with the meds and they won't worry about it and you can take your meds, whatever. But there are some times that they go to certain procedures or diagnostic interventions that they have to hold some of their medications. You just need to be aware of that. A lot of times the healthcare provider or the surgeon will let us know that. But if we're not sure, be sure you find out before you give them the meds. Sometimes, remember they would say, the doctors would say, hold or give the the blood pressure medicine with just a few sips of water. Sometimes they don't want you to give the blood pressure medication before surgery because then the anesthesiologist or the nurse anesthetist can give that blood pressure medicine IV while they're in surgery. So just remember that you got to find out that, okay? The first step in initiating any type of antibiotic therapy, if there is any ordered culture, always remember to do the culture before you do the antibiotic therapy. Okay, and you know why, because it can change what's being picked up in that wound or whatever they're called, blood culture. Okay, just remember that. All right, just watch for medications for pregnant or breastfeeding. Your first priority is always caring for the client, not the lab or the diagnostic test. Take care of your patient first. We've talked about that before as well. All your medication orders must be fully completed with everything you need on it, the patient, the drug, the dosage, the time, the route. While we're giving a PRN, those things must be completed before you can use a nursing an order. Right. I want you to see the difference between an antiplatelet medication, so I placed this on here for you, between an antiplatelet and an anticoagulant. Antiplatelets are usually prescribed for arterial blood disorders, such as arteriosclerosis, whereas the anticoagulants are usually prescribed for venous blood disorders. So there is a difference. For instance, Lovenox, and enoxaparin is the generic name. You would want to be sure you're looking at the platelet count for that. And I believe I have some of that information on this slide or on my comprehensive slide. So know what you need to document. Even if the pharmacy or the doctor did not say check platelet count, as nurses, we're responsible for knowing if we should be looking at platelet counts, if we should be looking at the INR or the PT, the PTT. It's important that we as nurses be able to identify that even without them telling us. It's our responsibility. Okay. All right. And again, the last thing here is nothing should run in the same line as total parenteral nutrition. You know, that has to have its own designated IV line. So that's yes. Right. Just a few more. I'm getting to the good stuff here. We're going to do some activity in just a moment. Important concept to remember that if a client develops flu-like symptoms within 24 hours after taking a new med, a granulosis could be occurring. In other words, it could be the medication is affecting their white blood cell count. A sudden drop could cause a patient to develop some kind of infection. So remember, if a patient has flu-like symptoms about 24 hours after taking a brand new medication, think, okay, what's going on in the body? Is there an infection problem because of the white blood cell count has dropped? Okay, so that's really important. All right. If the client develops a rash after giving a medication, it's usually the medication that's causing it. That's most likely the cause. Be sure you are familiar with the correct techniques for giving all types of medications. I know you learned that back in the fundamentals of nursing. However, that is part of a pharmacology, ATI, and NCLEX questions. So just make sure if you remember how to give eye drops and ear drops and, you know, those types of things. So just be sure you remember that. Now, the last piece here is that if there is an emergency situation, you know, we follow all of these nursing assessment, the nursing process, right? However, if it's an emergency, the treatment is usually going to be the priority over a full assessment or collecting of data. So if a patient comes in and they can't breathe, we haven't listened to the lungs or heart yet, right? However, if that patient is not breathing very well, short of breath, we're going to throw some oxygen on that patient. All right. Always, and remember also through oxygenation, you're going to use 100% rebreather mask if that patient is in dire straits, because we want to get them as much as possible. All right, because that's 100%, almost 98% oxygen flow to that patient. All right. All right. A couple of other things to remember as you are preparing for pharmacology. Check out the forms of insulin to include the onset, peak, and duration, short, long, intermediate, that kind of thing for the insulin. Remember to mix medications. Be sure you remember how to mix medications from 2 vials. That is specifically mentioned on the detailed test plan that students or graduate nurses must be able to mix. It doesn't necessarily have to be insulin, right? But just review how to mix those medications. If you're using 2 vials, which one do you do first? Because remember, with vials, you have to have the air. So kind of remember that. Also, I recommend that you kind of glance through the complications with IV therapy and for venous catheters, you know, like phlebitis, if you don't remember any of some of those things, okay? All right. Just to remember again, there's another remember here that NCLEX will not give us the trade name at this point. They stopped this a number of years ago, and the reason they did it is because there was a lot of legal issues using trade names and those types of things. So generic name is the only one that you're going to get. And sometimes even the drug may not even mentioned. So you just have to kind of know what kind of drugs that patient might need for a particular condition. All right. So let's check your knowledge. You need to be able to identify the medication category from the following suffixes. All right. Are y'all ready? You ready for this? All right. Dipines. What classification?
CCB?
Calcium channel blockers. Yeah. Right? Is that what you said?
Yes.
Okay, great. Okay, let's do that. How about AFil? How about erectile dysfunction? All right. Cain is what? Oh, you didn't see it. Cain. What kind of lidocaine?
Anesthetic?
Yeah, an anesthetic. Very good. All right. And of course, you all know statin drugs. What are they called?
Something CoA inhibitors?
Okay, that's detailed. Yeah, let's just call them an anti-lipidemic. All right. In other words, we're trying to make sure that they don't have any stuff going around in their bloodstream. Yeah. Okay, so that's fine. How about the ARN? If you see a drug, and the reason you need to know the suffixes is because there's lots of drugs that end with these. But if you know the drug of the ending and you know the classification, you probably can answer the question. Okay, because you will kind of have an idea, even if you don't know the drug. And you will get drugs on the NCLEX and on ATI that you do not know what the drug is. So what is an ARIN?
Anticoagulant.
Beautiful. All right. How about a PRIL?
ACE inhibitor.
Y'all are running. Y'all good. All right. How about this next one? Solone or Acone? Think of a drug.
Steroid?
Yeah, corticosteroid. And everybody knows this one.
Beta
blockers.
Yeah, you know that one. Okay. All right, here's some more. How about a Pam and a Lamb?
Benzo?
Yeah, benzodiazepine. Good. All right. All right, and a Anicillin? That's an easy one.
Antibiotics, your penicillins.
It's a penicillin. What is the other classification of drugs that if a patient is allergic to either one of those, you shouldn't give?
Cephalosporin.
Yep, cephalosporin's very good. Y'all are getting it. All right, here we go. Oh, I already gave you this one. IDE is an oral hypoglycemic. What is the Prazole or Prazole?
PPI.
Hydrogen.
Yeah,
PPI.
PPI. Yeah. You know we're doing a speed read here. Y'all notice that, all right? But these are here for you, so if you want to practice these at home until you get them, know them, it's for you. So how about a PRAM and an INE? Both of those are very similar.
SSRIs.
Oh, yeah. Yep. Looking good. Tylen?
TCA.
Y'all have all these short abbreviations. Be sure you know what TCA means. What does it mean?
Tricyclic antidepressant.
There you go. You won't see a lot of abbreviations on your NCLEX, so just so you make sure you know them. Fluoxetine?
Fluoroquinolones.
Okay. It's basically an antibiotic. And of course, your mycins. We talked about this one earlier, actually.
Macrolides.
Okay. Aminoglycosides, right? Like gentamicin, vancomycin. Those are the mycins. Okay. All right. Just a couple more pages here. These is a lot of them, but once you know these, your life will be so much easier when you're taking the NCLEX. All right. How about an ASE? What is streptokinase?
An enzyme.
Thrombolytics.
Yeah, it's a thrombolytic. It's a thrombolytic, yeah. Because remember, with your thrombolytics, they can dissolve a blood clot. However, remember that with your heparins, it prevents clots from forming. So there's a difference between the two. All right, how about azine?
Antiemetic.
Yeah, like compazine. All right, antiemetic. How about a phylline? What's theophylline?
Is it MAOIs?
Okay, basically a bronchodilator, right? It's a bronchodilator.
That's the aminophylline. That's aminophylline.
Okay. And VIR, that's a
Antiviral.
yeah, that's one we could. That's an easier one to remember. Okay. Tidine.
Antihistamine.
That is like amantadine, like hydrogen.
Okay.
Is
Okay.
that H2 inhibitor?
Yeah, something like that.
It's actually an anti-ulcer. Remember, I think it's the ranitidine they've taken off the market now, correct? Isn't that the one they just took off the market because of cancer in the stomach? Yeah. ATI will not be, you will not see ATI questions on ranitidine, even if you've learned it. They have indicated to us that because it has been removed from the market, they have updated their exams. So you probably won't see it on the NCLEX either. But just know that TIDINE is an anti-ulcer. But that particular med is being removed from that. How about a zine? How about an antihistamine? Okay. And the last one is cycline, such as tetracycline, is an antibiotic. That's all you need to know with that. Okay. All right. All right. How'd you do? Need a little practice? All right. So again, this is available for you online for you. So now let's talk about antidotes. NCLEX expects you to know some antidotes. So let's see if you know these. What's the antidote to acetaminophen? This is very important, class. Somebody comes into your clinic or into the ER and they've taken a whole bunch of Tylenol.
Acetylcysteine.
Perfect. Acetylcysteine, also known as Mucomyst. That's really, really important. The things that I put on these slides for you are the things that are so common and so very important to know. How about warfarin? What's the antidote? Everybody should know this one.
Vitamin K.
Vitamin K.
Yeah, it's known as phytonadione. All right, so vitamin K. How about cyanide poisoning?
I'm just gonna guess activated charcoal, but I don't know.
Sort of, yeah. It's called methylene blue. You may not see that one as frequently, but from time to time you might see that. I don't know. I can't say it's not on the NCLEX, but I just know it's one that we do see from time to time. Heparin, everybody knows that one, right?
Protamine sulfate.
Yeah, very good. How about MAG?
Calcium gluconate.
Yep. Narcotics, of course, is something that's very common to everybody now. Yeah, naloxone. Narcan is the trade name. Be sure you know naloxone. Okay, naloxone. All right, a couple more here and we'll be finished with these. Benzodiazepines. What do we give a patient who has a little bit too many benzos?
I don't know how to say it.
Starts with an F, is that what you said?
Yeah,
All right.
flumazenil, something.
Yeah, here we go. Flumaxanil, it's known as Romazicon. Okay, so this is important to know. How about digitalis? What's the antidote? Starts with a D. Okay. How about digoxin immune fab? Do you remember it now? Yeah. All right. And of course, magnesium. I think I just gave you that one. I think I did it twice, didn't I? Yeah. Well, so what is it again?
Calcium gluconate.
Yeah, calcium gluconate. And lead poisoning. You might see that in bees.
Inhalation therapy.
Yeah. They call it Susamir or Shimet. Okay, that's the poison for that. Or not the poison, but the antidote. There may be others. So as you are reviewing your medications, if there's one that pops out that says you really need to know this antidote, I recommend that you know them. Okay. All right. We're going to take a break in just a couple of minutes, but let's go ahead. As you know, with everything, we have to go through the nursing process. So basically, you're going to assess. But what are you going to assess for medications? Well, you know, to assess for the allergies, if the patient is sensitive to those or has a hypersensitivity. You need to know all their existing medical orders. We have to be sure that we know that if there's any contraindications. This is all part of pharmacology assessment, right? Of course, the interactions between meds or meds and foods. Don't forget, meds and foods. All right, or also could be a serious reaction. That's important, and not just with meds, because there's a drug-drug interaction, there's a drug-food interaction, a reaction as well. All right. Also, again, we've talked about the relationships here, and then of course the patient's response to medication. So that's what we're going to assess. How we're going to do it, we're going to check their vital signs, their lab results, and there's many other things, and I just put a few things here. All right, so let's look at the differences between side effects, adverse effects, and toxic effects. And I've given you the definitions here in a little bit more detail than what we spoke of earlier today. But again, you need to know the differences between these three, because you could have a test question that talks about a side effect, and they might throw in some adverse effects of that particular drug. So you'll have to know the difference between those, and of course, toxic effects as well. And usually we talk about toxic effects if there's some type of therapeutic level, and you need to be able to recognize therapeutic drug levels. All right. There's some of the common ones, but you have to be able to recognize if the patient, not necessarily memorize every word there or every number, but kind of know if a patient is on Lanoxin, for instance, or digoxin, and it's maybe 4 nanograms per mil. Well, we do know that that's going to be a toxic level. It's no longer therapeutic. All right, and so then you're going to start thinking, okay, well, if somebody is toxic, then what are the effects I'm going to see, those toxic effects? What's going to happen? And each of those drugs are different. So I'm not going to read through all of these, but these are just a few drug levels that we know we have to have therapeutic numbers with. And there's a few down here that I've also given you. All right, remember we also talk about lab values. Again, as a tip for you, just remember that, first of all, when you're looking at the question, you want to see what is the disorder presented in the question. They may not give you the specific disorder. They may give you maybe some symptoms of a disorder. All right. For instance, if you have a patient with gallbladder disease, they may not give you cholelithiasis. They may not say that. They want to know, do you recognize the basic symptoms of somebody with a gallbladder eruption, right? And so you need to know that, because then you need to know, okay, well, what lab value would I be looking at if a patient has cholelithiasis, all right? Then you have to determine if it's normal or abnormal. And of course, what are the body organs that are associated or affected by the particular disease? So if this patient is having nausea, they're having pain in the middle of their back, they can't eat, they're just nauseous, sick to their stomach, and you identify that that could be cholelithiasis, then you're thinking, okay, well, if that's that organ, well, what is another body organ that's going to be affected? Your gallbladder and liver, right? So that's how you want to think about your lab values and why they're so important. Calculations, you have tons of those calculations. And so again, all of this is things that you're familiar with. I would definitely want to make sure that you can do those IV administrations. And we've given you like 3 basics, and you've seen those already. So just know that you're definitely going to get some medications. And these are normally, in fact, they're always going to be fill in the blank. All right. So when you are answering pharm questions, you're going to ask yourself a few things. First of all, what is the classification of the med? Why is my client getting this med? Remember, if that client is getting a particular med, it may not be what the main use of the med is, as we talked earlier. So you've got to know, why is the client getting it? Then you have to think about, when should you question administering a medication? Because those are the types of questions that you can see on NCLEX and ATI. They could ask you, like, administering a medication, but maybe you shouldn't be giving that particular medication. All right. When should you question it? Is there a therapeutic range or level associated with that medicine, for instance, with lithium? Do I need to know a therapeutic range? What are my vital signs that I have to be monitored? What should we be monitoring with vital signs? Any other physiological parameters that you need to look at? So what should we be teaching our patient to keep them safe, both at the hospital or at home or wherever they might be at? The very basic of all common side effects, some adverse effects, and how are you going to know if that medication is effective? All right. So these are just a few questions as you were doing pharmacology, particular pharm questions. All right, just to think about. All right. All right, so there's a key to analyzing medications. For instance, class, reason for use, action, and interventions. So first of all, what is the class of furosemide?
Diuretic.
Okay, it's a loop diuretic, right? All right, good. Why do we usually give? What is the reason for this particular medication? What's the usual reason for giving this particular med? Why do we give like
Fluid overload or heart failure?
Yeah, excess fluid in the body, such as, like you said, heart failure or hypertension. Okay, we can actually give it for that as well. So what is the action? Not in depth, not talking about the cellular, where it is done in the loop of Henle and all that, but what is the action of this particular med? What does it do?
Fluid helps get rid of the fluid.
Yeah, it gets rid of the fluid, and there's a place that it does that, okay? So try to think of it in more simpler terms than just the details that you had to learn, okay? And then what are some of the interventions that you would do, nursing interventions or actions that you would do for this particular med? If you're giving a furosemide class, what would you think about that I need to be putting on my plan of care?
Electrolytes.
Check
Potassium.
what? Potassium, check that potassium level. What else?
Monitor blood pressure.
Okay, checking that blood pressure. There's another one that's really important. If your patient is on furosemide, yes, dehydration, you see that? So 3 interventions that you would immediately recognize, and this is only one sample, and you can use this for any, you can use this path for any of your meds. So these are the things that you'd want to look at. Of course, we're going to also talk about teaching, right? There's 2 things I want you to remember about teaching with furosemide. Can you think of one? What are you going to teach your client?
Get up carefully so you're not.
Yeah.
falling.
Yeah, orthostatic hypotension, absolutely. All right, what's another one?
Take it in the morning.
Mm-hmm. Okay. All right, take it. You can take it in the morning. All right. How about if we drink? Very good. How about if we drink water? Make sure our patients need to drink water because they're going to lose a lot of fluid. All right. What are 2 side effects? You already mentioned one.
Feeling dizzy.
Dizziness?
Dizziness, lightheadedness. Yeah. Okay. So when you're looking at medications, that's what you need to do. Something simple like this, not the entire drug book. Okay. You had to learn all that, but just when you're looking at a medication, the most important things that should stand out to you. And of course, what is one major adverse effect of this particular drug?
Reduced potassium.
Yeah, hypokalemia, absolutely. And the last thing we're going to look at when we're looking at medications, how to analyze these meds, is effectiveness. And I'll show you these. So in other words, you're asking yourself for this particular medication, is the urinary output greater than the intake, right? Did the client lose weight? Does the client have any sacral or peripheral edema? Where is this edema at? Do they still have it and they're still taking this medication? So you're looking at the effectiveness. Did the medication work? Does the client still have JVD, jugular venous distension? And about the blood pressure as well. All right. All right. Any questions on how you actually analyze a medication? Simple, to the point, just a few things in each of those sections, and you'll have those meds done or understood. All right. All right. So when we return from our break, we're going to look at selected medications, and we'll begin with the differences between anticoagulants and an antiplatelet. Okay. So let's see, come back at, it's 9:58, it's 10, come back at 10 minutes after, give you 12 minutes. so we can move on. There's lots and lots that we're going to do, and there's lots of activities later on that we're going to look at. Okay, and I won't be able to finish it today, so we'll catch it next week. And what I can't catch, you'll just have to do on your own, but I really wanted to do the questions, but we'll see. All right, I'll see you at 10 after. I'm so used to putting on my mask on. I got down in front of the computer and put my mask on. That's so silly. Yeah. All right. We have another minute or so. All right, class, it's 10 after. I'd like to continue to move forward. And again, at 11 o'clock, Professor Nicholas will come and do pediatrics with you. Okay, so we're starting now on, we were at this slide. There is a difference between anticoagulants and antiplatelets, right? So let me just show you here what I have. So you'll notice that anticoagulants will interfere with the clotting process. It's generally used for venous thrombi. And some examples are heparin, enoxaparin, and warfarin. And then your antiplatelets will interfere with platelet aggregation. And we use that for arterial thrombi. This very important slide to understand and to utilize in your practice as well as with your exams and stuff. All right, aspirin, clopidogrel, which is Plavix, and pentafoxylene, which is Trental. All of these, even if it does not say to check your platelet count, you must check your platelet count for these particular drugs, for these very common examples, okay? So I just wanted to remind you and to kind of give you a little tip here. It's not a lot to memorize. It's just things that you know, but hopefully it will help you a little bit. So the first thing I want to look at is I've given you a few drugs here that are common. What I have seen in the past where many students do not get these questions right with these particular meds. Doesn't mean every student in the class is not going to get it right, but so what I do is how I do this, and I pull some things out that are very important, right? So we do know that warfarin is used, okay, and the foods are important. That's why I put them in red. For instance, your spinach and your Brussels sprouts and those dark green leafy vegetables, broccoli, asparagus, all of those things are very, very important to know the types of foods. Now, there is a new thing now where they're saying that if you eat small amounts of this food that you should be okay. But in general, if you have another food to choose from, it's best to use another food instead of trying to feed them these things, because sometimes patients don't realize what is a small amount and what's a large amount. Okay, so be sure you know the foods, particularly for the use of warfarin. We know that some drinks can increase the effect of warfarin, which can cause an increased bleeding potential, and so I've put these up here for you. Cranberry juice and, of course, alcohol. We try to not do that at all. But cranberry juice actually can cause the way that the warfarin works in the body to increase its effect. So you're going to have many more bleeding problems with this particular drug. Some important things. We are going to assess the PT and the INR for warfarin, right? And we have to be careful to make sure that if someone is on warfarin, that they shouldn't be taking such as aspirins or NSAIDs or phenytoin, Dilantin, or allopurinol, which is for gout. So things to remember. So the numbers of PT and the INR, you just need to know some basic information on that. And then the treatment, as you mentioned earlier, class, you did good on that, was vitamin K. However, keep in mind that the treatment for an overdose of warfarin will not be effective for 24 hours or so. So it doesn't happen immediately. It's not like all of a sudden a cure-all. No, it takes time. So once we've treated a patient with for this overdose, then we still have to monitor for bleeding and all of that, just because we gave them vitamin K. Okay. All right. One of the reasons we don't do those foods, of course, as you know, is there's vitamin K in all those foods. So we have to be careful with that. All right. All right. Here's one, pentoxifylline, which is known as Trental. Basically, Trental is that particular drug that it decreases the blood viscosity, and the red blood cells become much more flexible. It doesn't stick together. It reduces the aggregation of like platelets and those red blood cells. So basically, we give Trental or pentoxifylline to cause things to flow much better in the body. And so that's why we actually use that. It is generally used for intermittent claudication, for vascular diseases, right? We know that we're going to watch for certain things such as bruises and petechiae. There can be angina and chest pain. That's a key. I should have marked that for you. That's unusual for us to see something like that. But if a patient is on this particular medication, they have a little bit of anginal pain or chest pain, that could be caused by that medication. Okay. All right. There's a usual dose. All right. And the other thing with Trental, just like with other medications, it takes time for these drugs to take effect. This one can take several weeks to even start working for the patient. So we give them this pentoxifylline, and then they go, oh yeah, their blood's going to be fine, and then and no, it's not. What could possibly happen is that they could still have some major issues, because it's not going to be effective right away, and that's true in many of our medications. Right? I think the only thing that I've seen is that really works fast is Lasix or furosemide. That goes real 5 minutes IV. That patient's in the bathroom. Okay. And so why do you think that a patient should avoid smoking for sure if they're taking this medication?
Isn't it constricting the blood vessels?
Yes, it's a very good, Uma. It's restricting the blood vessels, causing them to get a little bit more constricted, but which increases the problems with the platelet aggregation. So it's really counteracting this particular medicine and the purpose of why we give it for a patient. Important med to know. Very common. All right, your typical heparin. All right, we know that it actually prevents the clotting process from happening. So it's a good one for that. And so we use this a lot for, of course, DVTs or deep vein thrombosis to prevent them. And that's why you see this given a lot. And along with enoxaparin, that we use this post-operative surgery, or even with patients who are going to be in the hospital and they're going to be bedridden for a while. The healthcare provider tends to order a lot of Lopinox or enoxaparin as well as heparin. However, there are major side effects, and you're familiar with these. I just lit them up there. So be sure you know these major side effects. It's all about bleeding and with the use of heparin. Okay. We have to teach our patients about the use of heparin. So it's important things to teach them. So what would we want to teach them if they're going to be on heparin? If your patient is on heparin, what are you going to teach them?
To monitor
No contact sports.
No contact sports. That's a good one. What did you say, Uma? You started to say something.
To monitor the bleeding signs, like when they brush their teeth, if they're gonna bleeding or nose bleeding.
Very good. And, to be careful about the use of razors and, sticking themselves with a knife or things of that nature. Yeah, so we'd want to teach them about that. All right. And of course, we talked about the antidote earlier. If a patient is on an anticoagulant, when you take an IV out, how long should you hold that site after you've taken the IV out? What really is the minimal time that we should put pressure on it?
10 minutes.
2 minutes?
5 minutes.
Mhm.
5 minutes should be about the pressure rate, because even after 5 minutes, some patients still can bleed. So that here you're discharging a patient and you have held it for 5 minutes, or asked the patient to hold it for 5 minutes as you're doing other things in the room. They can do it if they're able. Let them hold the gauze. They could go out to the car and then all of a sudden, shoot, they start bleeding again. Important things to remember when you're talking about any type of anticoagulants. Patient teaching, because it will freak them out if they go out to the car and get home and all of a sudden from that little IV side, the blood starts pouring again. They will freak out. And so we want to make sure we are reminding them that just to put the pressure on, and at least for another 5 minutes, and not to, and it may happen, so we need to tell them that. Here we have a broad spectrum anti-infective, tetracycline. We still use that today. We particularly like to use it for syphilis and some other STIs. Of course, we always know about the contraindications. There are some common side effects with this particular med. So be sure you do know this tetracycline, what it does. There is photosensitivity and increased pigmentation in the use of tetracycline. So we don't usually give tetracycline to little kids, particularly under the age of 8. All right. And there are some life-threatening, you can see the life-threatening things I've put on there for you, and any type of interaction. So a drug that I've noticed over time that I've seen that students tend to miss this particular drug, and it's a common drug. Just a quick review for you. Okay. One thing that can happen as well is what we call pseudomembranous colitis. This is important. That's why it's in red. Basically, what happens is that this anti-infective, it tends to cause a lot of GI problems, diarrhea, pain, some anorexia. The white blood cell count goes up. The serum albumin begins to drop. Why? Why is that significant to respond to? Low serum albumin. What's going to happen? Why do we have albumin in our body, in our bloodstream?
It's not the fluid volume, so you don't have the edema.
Mm-hmm. Yes. There is remember that the albumin is what we call a water magnet, and the ratio of water in the bloodstream between the interstitial and intravascular and the interstitial cells will change with the amount of serum albumin. So that's very significant with this particular condition, which is an adverse effect. We always stop tetracycline if we find this, and then if we need another substitute antibiotic, usually the doctor can order Vanco or Flagyl, which is metronidazole. All right, so that's what we do with that. Tetracycline causes those super infections, kills off all the good flora in the intestinal tract, and then all the bad stuff shows up. All right, so that's why tetracycline can be kind of dangerous. Down here under teaching part, make sure it's important to remember to avoid milk or dairy products. Don't forget about the antacids. But the big thing here is that it can cause esophageal erosion if they take it and immediately go to bed, right? Tetracycline. And there could be some tooth discoloration, particularly with iron products. So tetracycline, although it's been around a long time and hardly costs anything anymore, it has some major side effects, but it works. and so we still use it. We are familiar with potassium, right? It comes in tablet form, extended release form, as well as liquid form. So let's look at potassium. You know, we used to have potassium chloride on the floors where we worked, as on the units, but there was a lot of mistakes made where nurses would grab the potassium chloride and when they should have grabbed the normal saline vials. And patients were getting increased amount of potassium chloride, which can cause deadly, arrhythmias. So they take it off the floor. We don't see it on the floor anymore. It usually has to come straight from pharmacy, and they usually mix it for us. But the potassium tablets are very common, very common. Be sure you know that with potassium, you have to check for hyperkalemia. All right, too much of this particular electrolyte or potassium can cause these things that I put up here: palpitations, EKG changes, which is very bad, oliguria, and I've given you a little bit more in depth there. You can read through that. Generally, the potassium level is 3.5 to 5, which should not be new to you. But we also are going to check for hypokalemia. It can also cause some depressed ST segments as well. However, not as common as it would be for hyperkalemia, but it is a problem. And potassium can be in these foods. Those are important to remember as well. Potassium is also in tomatoes, cantaloupe, which is something we don't think about, but tomatoes, and I didn't put it on here, I should have, because it's very common. We usually think about bananas for potassium, but cantaloupe and tomatoes have a high level of potassium as well. Okay. And we want to make sure that the patient is aware not to take all these over-the-counter products because it could cause interactions with the potassium. And licorice. A lot of our older population, geriatric populations, likes licorice. And a lot of them also have to take potassium supplements. So if your patient comes in, and they're older patient particularly, and they eat like bags of licorice, there's different kinds of licorice flavors now, and you find that they are hypokalemic and they have some swelling going on, some sodium retention, it could be that they're eating too much licorice and it's interfering with the potassium. So what are we going to check for? We always check for digitalis toxicity if the patient is taking this particular medication, digoxin, right? So the digitalis toxicity, be sure you know this, a very common thing as well, visual disturbances, the cardiac dysrhythmias as well. So if you have a patient who's on potassium, check, and they're taking dig, look for potentially problems, okay? Particularly a hypo level. All right, here's some nursing interventions I gave you as well. It is very irritating. We know that if we put it in an IV line that it can irritate the skin and cause, unfortunately, could cause cellulitis if we don't work with it and protect our patients. Right. We never ever push potassium chloride directly into the patient because, of course, that could affect their EKG, get them some problems. And we tend to use large bore needles when we are using this as an IV because it can cause terrible necrosis if it leaks out. And these are just some some labs and things that you want to monitor if you are giving potassium. Here's a few, yeah, that's it. Okay. The next one is magnesium hydroxide or some type of antacid. We use these for peptic ulcer diseases. And also, again, we've talked already about how to give this medication before and after, and we want to monitor the stools as well. This type of antacid can actually cause diarrhea. All right. So some other medications that we use for peptic ulcer diseases, I need to take off ranitidine. I forgot to take that off because we used to give it all the time. So we just delete that. But basically for peptic ulcer diseases, we can give them histamine H2 receptors antagonists, cimetidine, famotidine, those types, but not ranitidine anymore. I'm just wondering if through research they find that even famotidine can be a problem. I don't know what happened with that Zantac, but definitely a problem. Someone who has peptic ulcer disease, of course, we want to make sure they don't have caffeine and spicy foods and anything that has aspirin or NSAIDs because it irritates the digestive tract. All right. I need to make a note right now to remove that because I forgot it was on there. Remove ranitidine because it just came off the market. All right. We also are using proton pump inhibitors, and I've given you some examples here. This is Protonix, this one as well. All right, the Prazoles, as you can see. And with them, we want to make sure that we are monitoring certain things like liver test and bone density, the electrolytes. Right. And there's lots and lots of interactions with other drugs using these PPIs. So that's a little bit about PPIs. Just be sure you know those. Those are common. All right. Steroids, as we all know, that we have to discontinue steroids and taper them off because it can cause what we call an Addisonian crisis. And we do not want to see that happening. So basically, the steroids will suppress the body's normal response to stress, and so it actually causes adrenocortical insufficiency. So that's the Addisonian crisis. There's the signs and symptoms. Hypotension, of course, is a bad one. Could have some signs of shock. That's not a good thing, all right? And we can have this issue with the adrenal glands. So think of steroids and adrenal glands. They kind of come together. So we have to just taper them off so we don't develop Addisonian crises. And these are the signs and symptoms as well. At the bottom, you're going to assess for all these things that I've put on here for you. This is just a protocol, a sample. This is not for everyone. This just happens to be one that I wanted to show you. So you do a little bit over time and you decrease it and the body becomes adjusted to the lack of those steroids. So Addisonian crisis and steroids go together. So we have prednisone, which is a corticosteroid. And with prednisone, this actually can cause Cushingoid syndrome or symptoms like moon face. Remember the little patients that have the big moon face and they have weight gain and they have adrenal insufficiency as well. And they have all these other things here. They're really anorexic. They look terrible. Okay. So whenever you're using prednisone, you want to look for these types of problems. All right. Let's talk about a peak and trough. Particularly with vancomycin, there are other medications that we can do peak and trough with, but this is a very common one. Remember that the mycins can cause ototoxicity, and vancomycin can also cause nephrotoxicity with the kidneys. The BUN could become increased. There's going to be a problem with the albumin as well. So Redman syndrome, I'm sure you've heard about that one. This is where the patient becomes flushed in the neck and the upper body, and they look awful. That could lead to anaphylaxis. So whenever you are administering a mycin drug, particular vancomycin, look for these things. So in order for these particular drugs, yes.
I think he might be a slide behind on at least what we're seeing.
Oh, really?
Yeah.
Well, that's strange.
Oh.
Is everybody?
Are you talking about Vanco now?
Yeah.
Yeah, now we see it.
Okay,
I
maybe there
guess
was
there's a
a
little slight
time.
delay.
Yeah, well, we love the internet stuff, but these delays just drive us crazy, right? Thank you for telling me, and hopefully you're there now with Peak and Trough. Are you there now? Okay, I see some nods. Okay. Remember with vancomycin, and many of the Vicans like gentamicin, we're usually going to do some peak and troughs. And the reason for that is because we want to make sure that the blood level stays the same 24 hours a day, all right, because it's very therapeutic. So what I did here is I put peak and trough and what it means and what's the differences, okay? The peak, remember, is the time when the drug concentration is greatest, usually a couple of hours or maybe an hour after we administer the drug, all right? So that's the peak. The trough is where the drug concentration is the lowest. In other words, you can think of like a watering trough. It's kind of dips down, so you can kind of see that on a graph. And so generally we will do a trough immediately before the next dose of medication. Peak and troughs are tested a lot. So the example here, of course, is your vancomycin. All right. Y'all recognize nitro, nitroglycerin? All right, we use that. We use it for hypertensive crises. It's particular if we're looking at an acute state of hypertensive crises. Nitro is really regulated because it can do a lot of damage to our patients. Generally, that glass bottle that you see there, and by the way, nitro comes in a glass bottle. It reacts with plastic, so you have to see it on a glass bottle. And normally these glass bottles either have some kind of brown paper bag or a plastic bag over it or some other covering because it denatures in light. So it's kind of dangerous to use that if it has not been protected from the light. If the color changes on nitroglycerin, it can different colors, then you're not going to use it, all right, because there's something wrong with it, obviously. Now, here's that cyanide toxicity. Remember we talked about that earlier on today. And what did we say the antidote was for cyanide toxicity? Do you remember?
Methylene blue.
Excellent, very good. Methylene blue, absolutely it is. All right, so we can actually get, when we're using what we call nitroprusside, which is a relative of nitroglycerin, we can have that cyanide toxicity, and that means that the patient will become antihypertensive, it's an antihypertensive and it's vasodilator. All right, so we have to be careful with that. There is no filter. We'll be hanging this particular medication. We don't need a filter like we do, like in TPN, or we have to have a special filter for TPN. All right. There are some side effects, and you can imagine what happens with nitro, because you give the pill nitroglycerin for patients with angina. Generally, there's 3 max of those as well. You can get no more than 3 of those. However, one of the biggest things to remember with nitro, because of what it does, it drops the blood pressure. If the patient is also taking one of those erectile dysfunction products, then it could actually cause more severe hypotension, actually kill the patient. So be sure you know what medications your patients are taking, all right? Nitroglycerin, common as well. All these are common. I shouldn't have to say that. Recognize lactulose. This is that very sweet orangish looking fluid that we give patients. We can use it for constipation, but we use it a lot with our patients who have cirrhosis of the liver because they have a lot of ammonia buildup because the liver cannot metabolize correctly. And so we have to get rid of the ammonia, and we use lactulose to do that. Unfortunately, it does cause a lot of diarrhea on our patients. That's why we wind up with cirrhosis of the cirrhosis of the liver patients who's on lactulose. It can become so bad with the diarrhea that we have to use a rectal tube for those patients. All right. There's some action, and I mentioned it here as well. And there's a dosage. Check for those ammonia levels because what happens with a patient whose livers don't function, remember it does cause an increase in ammonia levels. And I put some numbers in here for you. The levels between 30 to 70 milligrams per 100 mils can cause hepatic encephalopathy, where the patient becomes confused or restless or irritable. So if you have a patient who's got a liver condition and they begin to be like this, first thing we're going to check is the ammonia levels, all right, because there may be some kind of encephalopathy that's occurring, and your doctor will most likely order lactulose, all right? And by the way, lactulose can also be given rectally because it's a liquid. Sometimes they order it rectally. All right, and then of course, if they are drinking it, sometimes they like it mixed with things, and you can mix it with water, milk, or fruit juice, all right? And extremely sweet. I've had patients who have taken this and they go, oh, this is so sweet. But sometimes they'll drink it directly from the cup because these are unit dose cups. All right, and so we will give this on an empty stomach. Lactulose. Iron, of course, known as ferrous sulfate. All right. We cannot break or crush or chew unless it's labeled chewable. They're designed differently if they're labeled chewable. Ferrous sulfate is not acidic, it's more caustic. It's like iron, and it can burn as well. We need to give it between meals with juice, and again, it does cause some upset GI symptoms, which I mentioned earlier. Black and red tarry stools. So just be sure if a patient is having those issues and they're taking iron supplements, just kind of remember what's going on with that drug or what happens. We don't like to give it with eggs or milk products or chocolate caffeine or chocolate and caffeine because it could interfere with the absorption as well. For ferrous sulfate or any iron products, we're going to use a straw because the straw tends to put it back in the further part of the mouth instead of on the teeth, and iron can stain the teeth, all right? And again, careful about giving it at bedtime because, as I mentioned, it's very corrosive to the body. Levodopa carbidopa, anti-Parkinson's agent, all right? One thing to remember with this drug, it's most effective in the first few years, all right? Long-term use, and I think I should have highlighted this here, all right? You know, even though we give it to help with Parkinson's disease, long-term use can lead to dyskinesia, jerky movements, you know, funny facial movements of the face, and head bobbing and chewing and smacking movements, those types of things. So they tend to try something different towards the latter parts of this condition. But we do use it, but it's better in the first few years, all right? I've given you some side effects and some toxicity. What is a blepharospasm? What's that? Anybody know?
Is that when your eyelids are twitching?
Yeah, a little twitching of the eyelids, absolutely. So that means you're toxic if you're taking this, and if you're getting a lot of that. All right. Again, with the patient, this can change. They can get like hypotensive with this. Their urine and sweat can become dark. So you want to make sure you're doing some good patient teaching with this. There's actually 3 more drugs that we use, and there may be more now on the market. Of course, there's all kinds of drugs out there, but these are just a few, just in case you are not sure about some of these Parkinson's disease drugs. I've put them up here for you. You should recognize rosindronate, which we talked about earlier, the ATEs, Actonel. We use this because it inhibits bone resorption. We use it in the Piaget's disease, and they tend to use this from time to time with osteoporosis. All right. And I've given you some examples of how to use this. Important to remember with here, okay? Always be sure that we give it with lots of water, all right? It takes a while for this to even work. And the patient should stay upright for at least a half an hour because this can cause a lot of distress in the esophagus area and cause lesions. Okay, and again, we don't break it or chew it or anything like that as well. All right, basically on an empty stomach. Okay, but it can be kind of discomforting in the esophagus. All right. How about this one, acyclovir? There's the VIRs for you. This is an antiviral. And we use this for herpes, viral herpes. It could be injection, of course, as well as PO. The major side effects here, the most important one here that's really an adverse effect is it's nephrotoxic. It can destroy the liver, the kidney. And so we also give it for herpes zoster as well. So acyclovir is kind of a common drug. And by the way, if the patient is going to take this, it's usually given for 7 to 10 days. Make sure the patient takes it for 7 to 10 days because it may not be effective otherwise because remember the viral load and all of that. So be sure they're taking it exactly as ordered. The leukotriene modifiers, all right, this is all about breathing, of course, for asthma, and I've given you a few here. Zarfucast, Xalutin, and Montelukast Singulaire. These are the most commonly used. Make sure you are reviewing some of these particular drugs because they're so common. All right, and so basically what they do is they decrease bronchospasms and they help us with edema and mucus secretions as well. None of these are going to be used, these leukotriene modifiers, for a quick asthma attack. These are just kind of long-term, daily kind of medications. And I put here pictures of it, but I wanted you to be aware that all three drugs, all three of these can cause depression, suicidal thinking, and behaviors of suicide. So anytime you're thinking of leukotriene modifiers, we've got to make sure I'm monitoring my patient's behaviors. And if they're getting depressed, don't forget to look at that. Here's a beta-2 adrenergic agonist, which is albuterol, Proventil. We use this a lot. You can see there's a picture of it there for you. It helps to relax those bronchial smooth muscles and bronchodilation. Doesn't take long to work. It lasts for quite a while, a couple hours or more. All right. Notice if it's taken with an MAOI inhibitor, a hypertensive crisis can result. Now, beta blockers may inhibit the action of this med. Why is that? Why do you think that this may stop this medication? What's a beta blocker do? What's the action? Go ahead.
Specifically works on lungs by dilating the passages.
Yes. It can inhibit. It can be a problem for taking a beta blocker at the same time. So just got to keep those things in mind. Yeah. All right. So albuterol, very common drug. Unfortunately, these are the side effects. Tremors and it just makes them nervous and restless, but it works. Here's another bronchodilator. Okay. This is your theophylline. I give you the onset, peak, and duration. There's your therapeutic blood level. Okay, it can become toxic, and especially in the geriatric client. It doesn't take much to become toxic using theophylline. Again, this can cause also that nervousness and restlessness as well. But the signs and symptoms of toxicity are listed here: rapid pulse, flushing, seizures, etc. Okay. So what is the therapeutic response? If you were giving this medication to a patient, you're going to see, did my patient have decreased shortness of breath? Or how's their lungs sound? Did it clear their lungs out because they were able to, to cough and deep breathe like they should? So theophylline, bronchodilator. So if you're giving a bronchodilator and a steroid inhaler, which one are you going to give first?
Bronchodilator with the steroid last, and make sure they clean their mouth.
Oh, yes. Yeah, because it can cause a real nasty thrush in the mouth. Yeah, because we want the bronchioles to dilate, then the steroid can get down inside the lungs. Good. So you would teach your patients that too, by the way, making sure they do that. Here's one. It's known as Orlistat. You can see this in the pharmacies. You can see them in the back of the pharmacy. You can see, if you look up at the pharmacy, their medication, you can see this one sitting up there. Of course, what this does, it helps to lose weight. All right, there's always side effects, of course. Patients need to be aware of what these side effects are if they're going to take that to lose weight. There is some liver stuff going on, pancreatic and liver. Interesting enough, though, why do you think the pancreas and the liver can be affected so much by this particular med? What does this medicine do?
Because of inhibiting the lipase, so that would be the fat enzyme that it's not digesting and sending to.
Excellent. Yeah, because this one keeps us from absorbing the dietary fat, but we have to have the liver to function and the pancreas and all of that kind of stuff. So you can actually cause more problems, and so that has to be monitored very frequently. Your liver function test and your pancreatic enzymes as well. Right. Another common drug is olanzapine, which is Prexa. It is an antipsychotic. We use it to treat schizophrenia and some bipolar as well. Notice that for geriatric patients, it's an increased mortality. All right. If the patient has a dementia-related psychosis, in other words, they can die from this particular drug. We don't use this a lot for our patients. We hope not. Hopefully not. There are some side effects, weight gain, etc. This one, you got to be watching here: heat stroke and hot weather. It's much more common to have this when you take this particular medication. But most people don't go into heat stroke, but with this medicine, it can happen. There is a therapeutic response. And this is what we're looking for. Did things settle down? Did they have less excitement or hallucinations or paranoia? So Zyprexa, used for schizophrenia. And as a reminder about schizophrenia, I put the DSM-5 criteria for schizophrenia on you, just so you know. How do you know if they're schizophrenic? Well, this is just one of. This is the DSM-5. This is how they determine it, right? And then they may put the patient on Zyprexa or olanzapine. Quick notes on some antidepressants, such as SSRIs. All right, just some quick notes for you. So be sure to just read through those. And here's some examples of the medications and Prozac. Right, so these are just some basic information on there. Tricyclics, some notes on tricyclics as well. Tricyclics such as amitriptyline are also known as Elavil. right? They actually use this for other things like arthritis and spinal problems. So they can use these antidepressants as well for that. Here's your MAOIs again. There are some serious side effects, and I've listed a bunch over there for you to kind of review. Right. When a patient is on one of these, you know not to use any types of foods that contain tyramine, and I've listed those there for you. Also, a very important concept to remember, tyramine. Okay. And the different types of foods. There are some atypicals, and I've listed like bupropion, which is Wellbutrin, all right, Zyban, all right. Basically, it has some side effects, dizziness, etc. Right. All right, true or false? Are you ready? Everybody ready? All right, here we go. A client taking paroxetine may experience serotonin syndrome. True or false?
True.
Yeah, yep. Paxil, SSRIs. All right, a client taking bupropion may experience sexual dysfunction. What is bupropion?
It's not used for smoking cessation.
Mm-hmm. Yep. So Wellbutrin, it's usually it's an atypical drug, so it's not a side effect for this particular drug. So a client who's taking isocarbazide can enjoy a meal of pizza and beer.
It's not MAOI.
Mm-hmm. So can they enjoy the pizza and beer?
No.
We're gonna have the.
Particularly the beer, right? They'll have to drink a soda, all right? Yes. So that's false. So this particular drug is also known as Marplan. It is a tyramine-containing food such as beer, cannot be used. And a client taking doxepin may gain weight. This is a tricyclic. It's called Prudoxin. And so weight gain is a side effect, unfortunately. Yeah. All right, so just some quick notes on your basic varieties of antidepressants. All right, we got about 4 minutes until our guest speaker is coming. Let me try to continue on to a couple more of these because I really definitely want to get into in a couple of weeks, we're going to do that comprehensive predictor review, and I definitely want to help you with that. Okay. All right, Flomax. All right, tamsulosin, which is for BPH, which is benign prostatic hyperplasia. It works mainly in the prostate, of course. Right. There are some side effects: dizziness, orthostatic hypotension. And an adverse reaction is priapism. This is basically a severe and painful penis erection. It doesn't go away very fast. In fact, sometimes it's hard to get rid of it. Winds up in the emergency room. And it can also cause some angioedema. So this is used for someone who has BPH. Another drug, filgrastim. Right? It helps to grow our neutrophils, helps us to fight infection. There are some common side effects as well. Unfortunately, filgrastim can cause thrombocytopenia or a low platelet count, some problems respiratory-wise, and actually cause hemorrhaging in the alveolus. We have to be very cautious of the use of this particular drug. But it's good because it stimulates those neutrophils, and we want to increase white blood cell counts, particularly with someone who's on anti-neoplasics like chemotherapy drugs. or even bone marrow transplantation. So filgrastim, Neupogen.
I have a quick question about the tamsulosin.
Yes,
Is it
the one, yeah, right here.
the one that like you're showing for BPH? Isn't that something to do with like reproduction too? Like for women or no?
It can be, but I don't know a whole lot about the women's production on this one. That was something I'd have to look up. I wouldn't want to tell you wrong. But I know that that's good. I'm thinking of, are you thinking of tamoxifen?
I will show you
Tom,
because I'm.
yeah.
Oh, so it says oh, I guess it's just used for hypertension too.
Okay, all right. Okay. I'm thinking of tamoxifen because it starts with a T, tamoxifen, which was we use for females.
Okay, maybe
For
that.
maybe that's what you were thinking.
Of.
Yeah. All right. Well, thank you for sharing that.
No, I just wanted to like clarify because that's what I remembered that for whatever reason.
Yeah. But this is the one, this is really, we use this mostly for this, although it can be used for other things, I suppose. Okay.
So females don't take it.
I have not known of a female to take it, but then I'm not a woman's health nurse. And I don't remember seeing that when I did my research on here, but I could be wrong. So if you wanted to look that up, that might be, yeah.
Thank you.
Sure. And by the way, this material that I got for the development of these slides and these drugs, I took from your drug book, as well as professional resources for drugs. So that's why it has all this material on here. But I just wanted to pull from a variety of sources for you. Okay. The next one is I don't see her yet. All right, lithium. We know that it's used for bipolar disorders, particularly the manic phase. There is a therapeutic level, 0.5 to 1.5 milliequivalents, and lithium toxicity is greater than 1.5 micrograms per liter. There are some side effects for toxicity, they're minor and major. So I think you probably should need to know the toxicity effects of lithium because that's such a drug we use all the time. All right. There is some things to think about with the overdose, how you're going to treat that overdose. So be sure you do know that lithium, bipolar, there's a toxicity and there's a therapeutic level for sure for lithium. Haldol, all right. It is used for psychoses. It's haloperidol lactate. It depresses the cerebral things going on in the brain, blocks transmissions of dopamine, that kind of thing. We do not use Haldol any longer with, generally with elderly patients. I know I grew up and I've worked in nursing homes and a lot of places, and we used to give a lot of Haldol to our older patients, but I guess through research and evidence-based practice, we don't give that to our older patients very much because it actually, particularly if they have some kind of dementia problem. Side effects, extrapyramidal side effects, and I've given you a bunch of things here to take a look at as well. You can read those. Dystonia, tardive dyskinesia, etc. So we want to be careful about removing this abruptly. All right, so Haldol, it's a good drug, but it does have some issues. Donepezil is Aricept. It is an anti-Alzheimer's agent. We also use this one in multiple sclerosis from time to time. All right, and there's the action for you, side effects, and how we should administer that. I think the important one here is to be sure you look at for a cholinergic crisis or an overdose, where the patient will have some twitching, they'll have some nausea and vomiting, they'll start sweating, they get real dizzy. So there are definitely some issues with this drug, but it seems to work pretty well. Tamiflu, all right. And you know, there's so many drugs now coming out. Now that COVID's here, we have all those vaccines and stuff, but we still use Seltamivir. It's known as Tamiflu. We do use that for influenza. Oh, Professor Nicholas, are you there? I see. Hi.
Hi, keep going. You're fine. You can finish up. We're good.
Well, I got a long ways to go, so I'm going to stop.
Okay.
All right, yeah, I can finish this up in 2 weeks. It's not a problem. The students need at least a 10-minute break. Is that okay?
That's perfect, actually, because yes, that's perfect.
Okay, class, we will pick up with this slide number 76 when we come back in a week or so. And we'll finish it, and then we'll definitely be doing our comprehensive predictor review as well at that time. And then Dr. Simmons will come in and do your med surg, so you'll have lots of material on that day in week 5, I think it is. All right, so I will turn this over to Professor Nicholas. Class, thank you for your participation today. I enjoyed it. I'll be hanging out, but she's going to now take over the class. If you need anything from me, you know how to find me. And Professor Nicholas, do you have anything you need me to upload into the students' Canvas?
Will I be? Yeah, just the PowerPoint I sent you. It's fine.
Okay. All right. So you just sent it because I haven't looked at my emails.
I sent it last night.
Okay. Let me double check the emails, and then I'll go ahead and send it and put it up there for students while they're taking their break.
Okay, perfect. And we'll start back at 11:15.
Okay. Thank you so much, Professor.
Good morning. Can everyone see my screen? Give me a thumbs up if we're good. Okay, cool. Awesome. Well, so good to see you again. I loved seeing all of you yesterday. That was so fun. And today we're going to just be doing a brief, very brief PEDS review. And honestly, we're really just going to focus on a lot of the topics that were missed on ATI because we know what you did well on. And so it'll just kind of be a quick, brief review just to get you ready. A lot of this information you had less than a month ago, and most of you all did the remediation. So most of you have already been back over this, but we're going to just do a quick, brief review, and hopefully you will feel a lot more refreshed and everything will come back fresh to you. So we will get started. Okay, let me go back one. Okay, so we have some alert items, and basically these are kind of like the big ticket items, things that NCLEX is currently testing on that they like to test on. So we're going to be really focusing a lot on activity. So what are our warning signs for toddlers? What are our warning signs? What are our safety concerns for teenagers, for school age kids, for all those different grades, those different ages? We're going to be talking a lot about hand washing. You always have to look for that risk of infection. Whenever you're thinking about what my next step is, what should I do next, that really should go through your mind. Is there a chance there could be some infection here? Because if there is, then that's going to kind of be one of the things we want to focus on. We already know, and we talked about this a ton last semester, that the earliest sign of demise or something happening, something going wrong, is that change in the LOC. So it's really important to focus on the LOC and knowing how to check an LOC dependent on the age. Obviously, airway is huge. So, sorry, I'm making sure that we have that open airway as well. And then, of course, my big thing, therapeutic communication, giving them that option. How would you like to talk today? Tell me more about that, right? And then, of course, obviously, we're always going to go back to Erickson and our age and our development based on that. And like I said last semester, you're never going to get away from PEDS, unfortunately, because some of you are like, yes, I don't ever want to get away from PEDS. And then others of you are like, no kids. But unfortunately, even in adult world, there will be kids. There'll be your patients will bring in their kids, their grandkids. You may have a kid. It just may be a crazy situation. So you never really know what you're going to get. Okay. So moving on. All right. Cardiovascular. Now, I know y'all all have kind of, talked about all the different types of congenital defects, but one of the areas that we really struggled in was digoxin. All right. So when we think about digoxin, it is going to be the same in kids as it is in adults, okay? When we think of digoxin, we're going to be thinking about that congestive heart failure. Are these kids now being pushed into congestive heart failure? And is there too much of something on board, too little, okay? So we know in general, dig is going to improve contractility, okay? It's also going to improve the cardiac output, okay? We want that output to be better because if that output is low, that is making that heart work so much harder. And just like going to the gym, when you bust out your reps and your muscles grow, that heart is also going to grow in size if it's having to work harder. It's going to decrease our venous pressure, which is going to be great because that's going to also help with swelling as the relief of edema takes place, okay? So a lot of times you'll see them have dig on board with Lasix. They will kind of work together, but typically we really do like to use dig. Now, what do we know is our initial sign of maybe they've had a little bit too much? Who can remember?
Vomiting?
Yep, absolutely. I don't know who said that, but great job. Absolutely vomiting, okay? And because of that, we know that kids spit up. So if it's a baby, it's really hard to know, is this just spit up or have they had too much dig, okay? Remember that when we first get them started, we're really gonna watch them. Typically the dose is calculated in micrograms. So on NCLEX, you might have a drug calculation for dig, and just know that it is very common to see that micrograms. And the biggest thing is, remember, we've got to check that pulse. So before nursing school, how many of you could accurately, you felt really good about checking a pulse, even if you'd never done anything medical? It might be hard for parents. Think about how hard it was for you when that heart rate was 140 and you had to get used to counting it, right? So for parents, we're going to have to teach them how to check the pulse. And then remember, our range is that 90 to 100, okay? Now, it will also be, a lot of the time, the doctor will write a specific number for each patient. But in general, the range that NCLEX wants you to know is that 90 to 100, okay? And the therapeutic level is going to be anywhere from 0.8 to 2. And we want to make sure that we keep it in a safe place. It's a little pill. It looks like candy, okay? So if kids were to get it and just start ingesting it, it could be really, really bad, all right? And remember, they're not going to skip or make up for missed doses. So if they miss that dose and it's been too long, then we're just going to wait and give it the next time, okay? So also we know we're going to give it an hour before meals or 2 hours after. So we want it on an empty stomach. And we want to make sure we're not mixing it with formula. Why would we not mix it with formula?
Because you're not sure they'll get it all.
Absolutely. What if they don't eat it all? How much do they really get? We don't really know. There's no way to measure. Plus, you know, it could cause them to spit it up a little bit more. So we want to make sure that we're not doing that, okay? Alrighty. So remember, they cannot describe feeling bad. So vomiting is that early sign because we think they're spitting up. Late sign is going to be that pulse, okay? So they may have anorexia, diarrhea, abdominal pain, muscle weakness, drowsiness, and hypokalemia can also increase the chances for dig toxicity. Okay, that's pretty much it. As you think about the cardiac different diagnoses, really focus on those big ones. You know, in general, it's going to be PDA, ASD or VSD. It will be tetralogy of Fallot, and then a lot of times they'll do like, oh, I don't even know, like, you know, maybe just like one other random one. But remember, when you're reviewing for NCLEX, remember how we're going to study. What are our obstructive? What are our increased blood flows? Remember to go back to those lists, because if you don't remember every single heart disease, heart congenital defect, when you learn it and you learn it based on the list, a lot of the time you can kind of pick and choose your answers based on that, okay? All right. So with renal, our big two things are going to be nephrotic syndrome and acute glomerular nephritis. So remember, acute glomerular nephritis is typically because of that GABA, okay? So when we're talking to patients that we are suspected of AGN, we're going to ask them, did you recently have a sore throat? Did you recently get diagnosed with strep throat? And most of the time, if they got diagnosed with strep throat, they're going to have been on antibiotics. So this wouldn't have happened. So that's why it's really important. Like, can you remember the child not eating a lot or maybe complaining of a sore throat? That's going to kind of be our sign. All righty. And so that infection is going to go and it's going to travel to the kidneys and get trapped, and it's going to cause inflammation. And now our output is going to be different and decrease glomerular filtration. So once again, we know that it's from a strep infection. And these symptoms are very similar to nephrotic syndrome. So remember, we've got to differentiate between the two, but it will cause mild edema. The blood pressure will be elevated, so we're going to want to monitor that. And then the big tall tale sign is that Coca-Cola urine, right? Mom, have you seen him pee or she pee? What does it look like? And, you know, they'll have that Coca-Cola urine. And they may have some blood. They may have a positive ASO titer, but they may have also a normal protein. Just depends on when you catch it, how soon, how early. So the biggest thing here is we're going to monitor that BP. We're going to encourage bed rest in that acute phase. And then if we need to give our antihypertensives, we will. Remember, we're going to monitor for seizures and know that this could cause congestive heart failure. But that diet is going to be low sodium, low potassium as well if they're peeing a ton. Daily weights and strict I's and O's. Now remember, with nephrotic syndrome, we're going to go ahead and bring in the big dogs with the steroids. But with AGN, a lot of the time, if we can treat the infection, if we can get them on antibiotics and treat that strep, we don't have to go to the steroids. Steroids for AGN are going to be more late stage when the antibiotics aren't working. Alrighty, but we will be using the diuretics and antihypertensives. Procardia is one that we will sometimes use. It's a calcium channel blocker, but remember with these, we can't cut it. It's kind of hard to give. But obviously our biggest thing is if it's a strep, we're going to treat it with antibiotics. Okay. Alrighty, hypospadias. So I know on the final you loved my pictures, but knowing that this is the ventral placement of the urethral, so the underside of the penis, okay? Whereas epispadias is going to be on top, and it is the most common congenital anomaly. So 1 out of 250. Remember, with these kiddos, we're not going to circumcise right away because we want to keep that to potentially repair. And our biggest thing is they need to feel like a normal boy, okay? So they need to be able to stand and pee. So that's kind of what we're hoping for, as well as for reproductive reasons as well. Obviously, if the sperm cannot get out to the right place appropriately, that's going to cause problems. But more so, it's really more about that psychosocial, that kind of how they feel. Alrighty. And typically, like I said, we will hold on to that circumcision skin until we want to go in and correct. The biggest thing is, you know, just being reasonable and kind of telling them what to expect. And a lot of the time, these outcomes are really good. It's pretty amazing what they can do. Obviously, if they are old enough to understand, we're going to explain it. But in general, most of the time, they're pretty young, so they may not understand what's going on. We just want to offer supportive care and pain management. And typically, the dressing will come off in 1 to 2 days. And they'll be able to take a bath after 3 days. Obviously, we want to look for bleeding, making sure the penis is not swollen or discolored. And just like with a circumcision, we want to use lots of KY, because the last thing we want to do is have that area that was repaired stick to the diaper and have to pull that off. That would be awful. So that's why we're going to use that petroleum jelly or KY to make sure that it is not going to get stuck on the diaper. Okay, so respiratory. When we think about NCLEX and ATI, they love to talk about croup and acute epiglottitis, okay? That was also one of the ones that were a trigger sign on your ATI. I don't really know what the question said, but there was obviously one question about this that most of you didn't do as well on, so hopefully we'll address it today. Alrighty. So remember, when we think of acute epiglottitis, we're thinking of basically what was caused by croup, okay? So the difference between epiglottitis and croup is that, who can tell me, what's the difference? What's our main warning sign when we think, oh my gosh, this is a problem? Anybody know? What?
Oh, I said when they're drooling, like you have right there.
Drooling is a sign, but remember that inspiratory stridor? That stridor, and not just when they're crying, that stridor at rest, right? When you hear that all the time, that's a problem, okay? So We want to make sure if we hear it when they're crying, that's very typical with croup. But once you can hear that all the time, that's a problem. All right. They're going to have that sore throat. They're going to be leaned over. They'll have that inspiratory stridor, and they will be in distress. Typically, the EMS will give them that racemic epi. Okay. So that's what we use to treat it. And remember, if we're giving them racemic epi, we know that epi is very fast acting. So we have to monitor them, because if that stridor comes back, we've got to be able to give it to them again. And at that point, they're going to get admitted. All right. Remember, the big thing they want you to know is don't mess with these kids. Okay. Don't do an x-ray. Don't do suctioning. Don't do anything to upset them until we know that their throat isn't closed off. Once we stabilize them and once we kind of get them to an okay place, then yes, we're going to go for a chest x-ray. Yes, we can do whatever, but we need to keep them upright. We want them to stay with mama and daddy. So the last thing we want to do is try to stick something down their throat to make it close off more, getting them crying. None of that we want to do, okay? And a lot of times this is prevented when they have the H influenza vaccine. So a lot of times we see this in unvaccinated kids. And obviously the biggest concern is if your throat closes off, then we're not going to be able to intubate you. We're going to have to put a trach in. So we really don't want to do that. All righty. So like we said, agitation, anxiousness, frightened expression, drooling. They do have this kind of like weird kind of sounding voice. You can hear that barking cough. And everything's going to be red and inflamed. They're going to have increased work of breathing. So keep them calm, put them on pulse ox. Remember, cheap and easy. Very, very easy. If they did get intubated or trach, then obviously we're going to do ABGs and IV fluids. Once we get them stabilized, that's when we can start x-rays and our exam. If it does happen, like I said, they're typically going to have that trach. If they can get them intubated beforehand, or if they were already intubated, then that's kind of what you have. But we really don't want to intubate them fully, because that is going to swell even more. So we need to start those antibiotics. And so typically, like if they are intubated, we try to get them extubated, because we don't want to have to put in a trach, okay? And so they may also be on steroids, which we know is going to reduce inflammation. And so we'll typically give them antibiotics if we do think it's a bacterial form of this. Tonsillectomy. Okay, so I've got some extra notes for y'all down here. Don't you love when I put those extra notes in? I know, I kept them in just for you because I love you that much. So anyways, post-op hemorrhage, we know that is a big deal, okay? That's why we're going to avoid things like red food, okay? Or anything that might look like bread. We want to make sure that they're not bleeding, but then we want to make sure they're on pain medicines and we're pushing those fluids, right? So we want to do popsicles and the lollipops with lidocaine in them. But we do, it's not very common, but we don't want them to bleed after. We know that they're probably bleeding if they're swallowing a lot, okay? Clearing their throat. If we see the red blood, if they're restless. And the biggest thing is we want them to have pain management so that they will stay drinking and eating, so they will stay hydrated, okay? And remember, this can also turn into an airway obstruction, so we have to watch for that. If they are bleeding, a lot of times they'll have to go back in and recauterize. Things like using a straw and messing in the back of your throat are going to cause those clots to come out. Okay. Hypothyroidism, another area some of y'all did great on, some of you did not do as good, and that's fine. That's why we're going over it today. I feel like there's a lot of people like I could see that like focused on certain things. Like I said, I didn't go over a lot of the heart defects because y'all killed it on that. So some of these are really just areas that I saw some of you struggle more in. And that's completely fine. That's why we're going over it today, because we want it to stick, okay? Okay, so congenital hypothyroidism, we know, is that inadequate thyroid tissue development in utero. It's when they're kind of born with it, okay? A lot of times it takes us a little while to figure that out, and we're going to see that low T4, okay, and high TSH. So that's one thing I really want y'all to remember is low T4. I think some of you kind of got a little bit confused on what was low, like was TSH low, was T3 low, what was low? So with hypo, think T4, okay? That's what was low. And typically we can see this in the newborn, especially if they go past dates. If they're very hypoactive, delayed meconium, feeding problems, jaundice, or hypothermia, those are kind of some signs. And the biggest thing is when they're untreated, they're going to have that coarse hair, all the same symptoms that you would see in adult: constipation, hypotonia, coarse hair, lethargy, sleepiness, flat expression, large protruding tongue. So a lot of times we want to test for this, especially with PKU, which we're going to talk about a little bit, because it can lead to intellectual deficits. All right. So the biggest thing here is we want to make sure we're performing that newborn screening before discharge and assess the newborn for signs and symptoms of this. If they do have it, we're going to teach them about making sure they're getting that Synthroid, and they will have to be on it lifelong, okay? So they'll be giving that in the morning. They want to check the pulse beforehand. Remember, they can have an overdose if there's a rapid pulse, weight loss, diarrhea. Basically, if they start having all the symptoms of a hyperactive thyroid, then we know they've probably gotten too much medicine, okay? An underdose would be that lethargy, fatigue, constipation, poor feeding. So those are pretty simple. As long as you know the symptoms of hypo and hyper, then you know what is an underdose and what is an overdose. And of course, they're going to be checked periodically throughout their life. Alrighty. Type 1 diabetes, another topic. Okay, so remember our 3 Ps, okay? Polyphagia, polydipsia, polyuria, okay? They're going to have hyperglycemia, weight loss, unexplained fatigue or lethargy, headaches. They're going to have that fruity breath, especially if they're in DKA, slow wound healing, and changes in LOC. Remember, with our girls, a lot of the time, we find it because of a UTI or what we think is a UTI. Remember, I told you that story about how I never checked the results of the urine test, and then when I finally did, it was like 3+ glucose, and we were completely treating her for the wrong thing. Don't be like that, okay? Let my mistake help you remember. Always check that glucose level when I'm looking at my urine dip results. Obviously, the long-term effects are going to be failure to grow at a normal rate, infections, neuropathy, all the things you know about in the adult world is still going to be the same, okay? Cardiovascular disease. My husband's brother had type 1, and he was completely non-compliant his whole life. And he actually died around age 30 because he had been on dialysis. And if you're not compliant and you don't do what you want, if you eat what you want and you don't give insulin, it's going to cause your kidneys to fail. So we really want to make sure that they're actually treating and staying compliant. So remember, NCLEX loves to ask about exercise. What do they need to do if they're going to exercise, people? What do we got?
If it's low?
Be prepared, right? If they're going to exercise, you know they got to have a snack, right? So we want them to have some carbs before because they're about to burn all those carbs. So we don't want them to get low, so they're going to snack before, okay? And always have an extra snack. Always have some juice, that kind of thing. And just also think about, like, they're probably not going to be, you know, marathon runners. Or if they are, they're really going to have to stay with gels or whatever. So think about the exercise and just think about, okay, if I'm on the field, if I'm doing 2-a-days, then I'm going to have even more, and you're going to have to adjust accordingly. There's tons of pro athletes that have type 1 diabetes, and they do an awesome job, but I'm sure they have tons of snacks. So just be prepared for that. Alrighty, so some talks about insulin. The biggest thing here is that when there's illness, when there's infection, we're going to need to make sure that we monitor that insulin and that we know that if they're sick, if they're, you know, if there's infection, they're going to require more insulin. Okay. And so a lot of times people don't want to give more insulin because they're like, oh, well, it'll be fine. They're sick. They don't feel good. But you actually do have to monitor more strictly. And you also have to make sure that they're getting what they need. Okay. So we're also going to allow the child to take part in application of insulin. And as they grow, we really want to push them to trying to get a pump because that will be less sticks. And so we really want to make sure that we're teaching those signs of hypo versus hyper. So who wants to tell me the difference between hypo versus hyperglycemia? Anyone?
Isn't hypo like the cold and clammy and like diaphoresis?
They may go unconscious if they get too low. They're going to have that weak, thready pulse. With the hyper, what are we going to see?
Polydipsia, polyphagia, polyuria.
Yep, all those main signs. They're going to be very anxious. They'll have that fruity breath, etc. Okay. So remember too that if they are sick and they're having to do more insulin, we're going to be checking their urine. If someone comes in DKA, every single time they pee, we're checking their urine to check those ketones, okay? And ketones are a sign of acidosis, so we have to be careful about that. All right, so here's your signs. Just in case you're wondering, here it is. Hypos, the headache, tremors, lethargy, confusion, slurred speech. And remember, babies can't tell you this. So for them, they're going to get really sleepy, okay, and sweating. And with the hypo, then we're going to see that syncope, weakness, blurred vision, the 3 Ps. Real quick, not on your slide, but just kind of a quick review, because I know there were a couple little questions about insulin. I know you cover all of these in the adult world, but just as a reminder, our fast acting insulins, those are going to be Novolog, Humalog, and Aptria. And this is normally given right before a meal because it's going to start working within 15 minutes. It's going to work the best between 30 to 90 minutes, and it'll last about 3 to 5 hours. I have a chart here. I'm going to copy it and I'm going to paste it in the chat just so you have it. Okay. But remember, long acting, that's going to be like our Lantus or Levemir, 30 minutes before evening meals or at bedtime. It will start working within an hour, and it typically will be steady over time. Our short acting insulins, also called our regular insulins, that's what our drips are going to be. Okay. So if we have a patient coming in for DKA, remember, first and foremost, we're always going to start them on fluids because it's going to take a while for the insulin to get there, the insulin drip to get there. But it is going to be a regular insulin drip. Okay. And so that's going to be like a Humulin or a Novolin. And it's going to be 30 minutes before a meal, and it'll work about within 30 to 60 minutes. And it typically will last for about 5 to 8 hours. So it's pretty good, but it works the most between 2 and 4. Then you have your medium or your intermediate. Those are like your Humulin N, Novolin N. It's the same. One just has an R and one just has an N. And then you've got your like fast acting and the, like if they're combined, it'll be like a Humalog mix. And so you can have kind of a fast acting and a medium, which would be like your MPH, or you may have a short acting and a medium. So they're all going to look a little bit different. Okay. And so we just need to make sure that we're like making sure they're actually getting the right type. Like obviously if they're super high, you know, you do want to give a long acting, but you also want to give something that can affect them right away as well. Alrighty, let's talk a little bit about VP shunts, okay? So remember, a shunt is for hydrocephalus, okay? It's a little tube that goes in the brain all the way down to the belly so that any extra CF fluid can be drained. And remember, it is very, very common to have shunt malfunctions, okay? Why do they have so many shunt malfunctions? Someone tell me.
If the child keeps they're growing.
Yeah, the child's going to keep growing. So it's going to have to keep being adjusted and keep and keep being changed, okay? We know when they are having a shunt malfunction, typically they're going to be irritable. They're going to have that shrill cry. So we tell the parents, don't just call if they're fussy, like a normal fussy. Call if they have that shrill cry. They won't eat. They're tired. Remember, their pulse when the shunt is malfunctioning is going to go all over the place. It may be high, then it may get really low. So whenever a VP shunt patient comes in, the very first thing I'm going to do is put them on pulse ox, so I can monitor and make sure they're not bradying down. A lot of times older kids that can complain will complain of a headache or a change in LOC as well. So the biggest thing here obviously is if we see that bulging fontanelle, that's why any baby, typically 18 months or less, I'm checking that fontanelle. I'm just doing that little head rub, making sure there's no bulging, there's no depression. They may even have seizures if it gets too out of whack. And so we want to make sure that we are assessing them. And people, there are kids that have VP shunts, just because they have a VP shunt does not mean they're going to have an intellectual deficit. Typically, they will look the same, and mentally they may or may not have a deficit. It's not like a death sentence. It's not like, oh, yep, these kids are always going to be delayed. Some kids are completely fine. We do know they can get infected, so anything over 100.5, they're going to have to come to the ER for. And actually, if they don't have hair, you'll actually be able to see that swelling. They may have a stiff neck. We'll need to monitor INO closely. And a lot of times they will do a tap at the bedside where the doctor will come in and literally tap and pull off fluid at the bedside. So the biggest thing is to watch for that increased signs of ICP. And then obviously we have to prepare them for multiple surgeries. Alrighty, another area that we kind of tended to struggle with was meningitis. All right, so we know that bacterial meningitis is caused by bacteria, where viral meningitis is caused by a virus. Viral meningitis, we're going to see that a lot of the time in like dorm rooms, summer camps, where there's a lot of people, okay? And viral is a lot easier to treat and the life expectancy is much greater, whereas bacterial can be very deadly, so we have to treat it very quickly. And because we have the H influenza vaccine and the pneumococcal vaccines, we really don't see this as much. That's why all babies under 8 weeks that have not been vaccinated will have a lumbar puncture, just to rule this out. How many of you got to see a lumbar puncture in clinical? Did anyone get to? Pretty common thing. Remember, holding is a big deal. That was
did.
Who said yes?
Melissa.
Yay! How old was your patient?
Oh, it wasn't our patient. We were actually like watching her for another lady. In her 30s, like early.
Oh, wow. Okay.
Yeah, but she was in so much pain.
Yeah, it's interesting because with the babies, typically, like I said, once we get that needle in, they fall asleep because we're using that sucrose. Remember, anytime there's going to be pain with a baby, we're going to use that sugar water in a passy, okay? That's going to be like the baby crack, okay? But we know obviously this can be caused from lots of different types of bacteria. And so here's the big thing, okay? They're going to be on droplet protection, but this can kind of, once we start treating this may change. And we see this, like I said, in school age and teens. And this can lead to DIC, which can be very dangerous, and it appears as an extension of other bacterial infections. It's kind of like what came first, the chicken or the egg? And the biggest thing is that if it gets in the CSF, then we have a big problem and it can potentially lead to death. So we know we're going to do a lumbar puncture. That is the definitive gold standard, what we have to do. But the biggest thing here is that they are going to present with fever and intracranial pressure, different signs of increased ICP. So what are some of those signs of increased ICP?
Decreased LOC.
Yes, and typically headache as well. Our pulse may change as well. So Alrighty, and then the biggest thing is obviously we can treat it with antibiotics, which is what we want to do. So very important there, and just making sure that we're treating their pain as well. So you may have that non-bacterial viral aseptic meningitis, and this is typically from a virus. A lot of times we see this with measles, mumps, herpes, even leukemia. My daughter had, what did they call it? Chemo-induced encephalitis. Basically, she had too much of her chemo, which then caused a form of this or kind of encephalitis. So there's a lot of things that can cause this. They may have headache, fever, malaise. If it gets bad enough, they can even have seizures. And so with that, we're going to be using those basically symptomatic treatment. Obviously, we're not going to give an antibiotic, but typically we will be doing pain management, fever management as well. Alrighty. One other thing, I have one other note. Let's see here that I wanted to say. I will come back to that. Typically, they will be on that precaution, at least for the first 24 hours, making sure that they will be on that droplet precaution for the first 24 hours. And then sometimes that can change once we've started to treat that. And it depends on the type of meningitis it is. Obviously, if it's like a tuberculosis meningitis, then that's going to definitely be airborne. But in general meningitis is going to be contact as well. So each hospital will have those standards set. So hematological disorders, here we go. Okay, so we know that with blood transfusions, we can see a hypocalcemia. The biggest thing is we want to make sure that if we are going to do blood, that we have a calcium level before and after the transfusion. And if there is any type of signs of, muscle cramping, fever, change in blood pressure, that kind of thing, we're going to stop that infusion. And we're going to talk a little bit about leukemia when we get to the end. The biggest thing, I think you'll miss some questions on HEI about leukemia and the treatment, and that isn't, we didn't really talk a ton about treatment. We did a little bit, but this is just a reminder with leukemias, we are going to start with chemo, okay? So we will start with chemo. Most of the time, if we give chemo and we give enough of it, then it can cause all those leukemic cells to go away and they can be in remission. If the chemo doesn't work, that's when we go to radiation or bone marrow transplant. But our first line of treatment is chemo, okay? So that's just a quick review of that. Sometimes you may see an inguinal hernia in kids. It is most common in boys, and it can be a visible mass in the scrotum. In the first year of life, it's very, very common to see these. In fact, we just tell the parents to kind of push them back in sometimes. But like I said, if it does persist, then a lot of the time they will have to have surgery to fix that. With a abdominal hernia, that is one we'll really see a lot of, and those are the ones we can push in a lot more. Most kids that have the abdominal hernias at the umbilicus, a lot of the time it's very common in that first year of life, and they will grow out of that as they grow. But the inguinal hernias, those are the ones that really do have to be repaired more frequently. Hirschsprungs, I have a picture of this. We did talk about this, but remember, NCLEX might call it aganglionic megacolon, and that is when they don't pass that meconium within the first 24 hours. And we're going to typically need to do a biopsy to see if there is an absence of ganglionic cells, which is how we're going to diagnose it. I have this little picture. So there it is. Then they're not being able to pass stool, or if they are, it may just be like jelly-like stool because they are not being able to pass it. So remember, we're going to have surgery. Typically, they're going to go in and they will get a colostomy, but that is something that as as they go in and repair it, then that can be taken back down. So stool with dissension, enterocolitis may happen, neck may happen if we're not careful. Alrighty, so once again, we do that barium enema. We will have to confirm with a rectal biopsy because we want to make sure there are no ganglionic cells there to be able to diagnose. If there are, then we know it's not Hirschsprung's. So there it is. There's our temporary ostomy. And then after we fix it, then we'll do the pull-through procedure. A lot of times when they go home, the parents will have to do the anal stretching, which is always a fun thing to have to do and teach. But that helps them stay open once they do have surgery. Alrighty, so I've got a list here because we're getting close to ending. And this is going to be posted. These are things you should probably review, okay? If I was going to study for NCLEX for peds, these would be the big ones that we just talked about, okay? But I did add in a couple of things in there, okay? And then I also listed, if you look here, these were all of the topics that I saw less than, like, this is it. There was a list of like topics to review, but these were the big ones that y'all mainly struggled with. With sickle cell, just remember that with sickle cell, anytime there's an infection, they have to come in. If they have a fever, they have to come in, okay? But with sickle cell, all we can do is push fluids and give pain meds. That's it, okay? We want to make sure they're not like, you know, struggling to breathe and that kind of thing. But in general, we push fluids and we give pain meds. And if their hemoglobin is low enough, we can give blood. They do need to stay immunized because they're at a high risk for infection because they don't have the blood they need to be able to fight infection. We talked a little bit about early signs of brain tumor, how they're going to have a delay in mentation. They may be able to walk and then all of a sudden they're not able to walk. They may be vomiting in the morning. Remember, anaphylaxis is a severe, it can cause death, okay? What are we going to give? If a kid starts having their throat close up, they start having hives and swelling, what are we going to give?
Epi.
Epi, okay? After we give epi, there's some other things we're going to give. We're going to give a steroid, okay? We're going to give Benadryl, and then we're also going to give an H2 blocker, like a Zantac, okay? Which you're like, oh my gosh, that's a heartburn medicine. It is, but it's also an H2 blocker, which is what was released, histamines. So we call it the triple threat, okay? Benadryl, steroids, and an H2 blocker, typically like a Zantac, okay? Like I said, you do want to review kind of those bicycle safety, making sure we're decreasing risk in adolescence. And so these are just some things that you can kind of just use as a way to review. Remember, we did talk about PKU and Dr. Richmond talked about it as well, but that is that phenylalanine where they have too much and so they have to avoid certain foods. All children should be tested for this. And then we talked a little bit about Mickel's diverticulum, but this can typically happen in the first year of life. They don't know it's happening until all of a sudden their hemoglobin is completely out of whack, and then they have to go in and treat it. Remember, with gastro, heart rate is going to be up because they're going to be dehydrated, okay? And they're going to be vomiting. So looking for those signs of dehydration is going to be very important. And then with varicella, I don't remember what y'all missed. I think it was just the fact that they needed to be on contact precautions for that. So it can be transmitted in the air or through the skin. So that is pretty much it. I know that was kind of like a low down and dirty kind of get it done, but hopefully this PowerPoint will help you when you're studying for NCLEX. Y'all all did a really good, we did not have anyone below a level 1, and I know that it'll kind of all come back, but just wanted to touch base on some of these things that you may see and just kind of give you like a study guide. I would honestly take these 2 slides, this one, and use it as a study guide when you're reviewing for NCLEX. You know, I always tell my students, when you're preparing for NCLEX, you should be doing 100 questions a day. Because just like with the test, I can only ask you so many ways a certain question. So between now and when you take NCLEX, you should make your goal 100 questions a day. I know that sounds like a whole lot, but I promise if you do that, you're going to pass, because you're going to have seen so many questions and you're going to get used to answering them. Y'all know this stuff. Y'all are going to do awesome. I think that's all I have for you. Any questions?
Professor Nicholas, I wanted to thank you for being here. I think I heard someone ask a question. Go ahead.
No, I just said thank you. That was helpful. Like a good summary of everything.
I agree definitely, Kayla. Professor Nicholas, I appreciate you coming today and sharing your expertise with these students, and great PowerPoint. Love it. Thank you so much.
Okay, thank y'all.
Okay. All right. Thank you. All right, class, it's time to go. You go enjoy your lunch, and I will see you again.